that shoulder doesn't clear that pubic bone and is stuck. Hello everybody and welcome back to my channel. My name is Elizabeth. I am a labor and delivery and postpartum nurse, certified childbirth educator, and mom to 3. And today I wanted to come at you guys with a quick video all about shoulder dystocia. So we're going to go a little bit into what is shoulder dystocia, what things can be predictive that one might occur in labor, what things you might be able to do during labor to help reduce your risk of a shoulder dystocia, and then also what your care team will do with you to manage a shoulder dystocia if it does occur. Now this video is in no way meant to make you feel stressed or scared about labor or about shoulder dystocia, just to give you some education, because I really believe knowledge is power, and when we know what could possibly go on in our labor, sometimes that can kind of help us reduce our stress and anxiety, because you can know what kind of things we will do to modify or fix the problem. So without further ado, let's go ahead and jump into it. Make sure to subscribe, like, comment, all that jazz on this video. It really helps me with the algorithm, and let's go ahead and do it. So shoulder dystocia, as defined by ACOG, is an unpredictable and unpreventable obstetrical emergency that occurs anywhere from about less than 1% of births to up to 4% of births. And simply what occurs is that your baby's head is born, and then the shoulders get stuck. Either most of the time the top shoulder gets stuck under the pubic arch, sometimes the bottom shoulder gets stuck on the tailbone. And so the shoulders are stuck, the head is delivered, and the rest of the body has a hard time coming forward on the next contraction. So if that head to body delivery time is more than a minute, if that baby isn't restituting, if we're having to use any of those shoulder dystocia maneuvers that I'm going to talk about, that is when we define your birth as including a shoulder dystocia. Why does this happen? What is exactly occurring? Let me go grab a baby. I unfortunately do not have a pelvis on me, but let me grab a baby. Most of the time when our babies are being born, picture a leg on each side. I'm just going to be on my back for this demonstration because I think it's the easiest to see. The back of the head is going to be coming out, and then that head is out, and my hand is going to act right now as the vagina. So the head is out, and then the baby has to do something called restitution or external rotation, where basically that baby is like, okay, head is out, now I need to move these shoulders so that they can fit under the pubic bone and out, because if you come out like a linebacker and you don't rotate, well, you're going to be totally stuck. So your baby is so smart and does this on their own. They go to one side or the other and then deliver that top shoulder and then the bottom shoulder, and then they're born. Smart kiddo there. So what can happen is, for some reason, for whatever reason, maybe it is how the baby came down, maybe it is because the baby is larger, that shoulder doesn't clear that pubic bone and is stuck. So there are a few things that we can look out for when you're pushing that could be a sign that a shoulder dystocia might be happening. The biggest one is called turtling or turtling sign, where basically we're doing a lot of going out and coming in, almost like a turtle going out and coming in its shell. And what that tells us is maybe those shoulders are gonna get hung up on the pubic bone. The other thing we might see is when the head is already out, that baby is having a really hard time restituting or doing that external rotation to one side or the other to pass underneath the pubic bone. Now, I feel like a lot of times we think big babies are the ones who get their shoulders stuck. And while it's true, a larger baby could have a larger diameter or a larger area that needs to pass under that pubic arch, doesn't necessarily mean that all big babies are going to get their shoulders stuck, or if you have a smaller baby that their shoulders aren't going to get stuck. What's really happening is that your baby's shoulders should enter at kind of two separate planes. They shouldn't be stacked one on top of each other. And a lot of times when they end up getting stacked one on top of each other, whether it's due to baby's position or how quickly the birth occurred, when they're on the same plane, that's when those shoulders can get stuck. I think that's really an important differentiation to make. It's not just because your baby was big necessarily. Those two things might go hand in hand, but they also can happen in absence of each other. So what are some risk factors for a shoulder dystocia? Now, what ACOG, or the American College of Obstetrics and Gynecology, says is that they are unpredictable and most of the time unpreventable. And in saying this, what they mean is, even though we have some things that may put you at a slightly higher risk for a shoulder dystocia, they don't really act as a super good predictor or a way that we could just say, okay, we know you'll have a shoulder dystocia. Let's move on to an alternate route of delivery like a cesarean birth to avoid this potential medical complication. We always will have these in the back of our mind. If we have these risk factors, if we know that you have these risk factors, we're going to be prepared for a shoulder dystocia. And if one occurs, we've got all the team members in place where they need to be. And if one doesn't occur, fabulous, because babies are really good at the most part of figuring out exactly how to get out of your belly. They are smart cookies. So some risk factors that we see are abnormal pelvic anatomy, or a tight pelvis, which again, we wouldn't know until birth happened. There's no way to know if your baby is or is not going to fit through your pelvis because the pelvis is a mobile structure in birth thanks to that hormone relaxin. Short stature, just because we might have a little bit less room for baby to rotate and move around. But again, short women have big babies vaginally all the time with no problem. Multiparity, or it's not your first baby. And that might be because when it's not your first baby, sometimes labors tend to go a little bit faster, and sometimes too, babies tend to be a little bit bigger because a really fast labor sometimes doesn't give the body or the baby that ability to restitute really well and do that turn that they need to do, so sometimes they end up getting stuck when labor is really fast. Conversely, if labor is taking a really long time, or pushing is taking a really long time, that might be a clue to us that however baby is positioned in there maybe is going to cause a little bit of an issue with their shoulders getting stuck. Gestational diabetes, particularly the poorly controlled blood sugars and large weight gain, are both risk factors for larger babies, and so both of those things potentially might put us at a risk for a shoulder dystocia. But again, big babies are born vaginally without shoulder dystocia all the time. A few weeks ago at work, we had a baby that was nearly 11 pounds, born vaginally, no shoulder dystocia. So again, we were prepared because we knew the baby was big, but that baby proved to us that he knew exactly how he needed to be born. Some other risk factors that kind of come from our end are using forceps or a vacuum to aid with delivery, and that again is because it doesn't allow baby to find that really good position to have those shoulders on two separate planes and that way fit their shoulders more easily through the pelvis. And then having a shoulder dystocia previously does put you at a slightly higher risk for a subsequent shoulder dystocia because again, maybe it is anatomy, maybe it is baby size. We don't know exactly why a shoulder dystocia occurred with your first pregnancy and birth. And so depending on what some of the side effects from that shoulder dystocia were for you or for baby, that might be a conversation that you have with your provider where you decide that you would like to either schedule an induction at 39 weeks to potentially reduce the risk of a shoulder dystocia, although sometimes inductions can put us at a higher risk for shoulder dystocia, or potentially that you would like a cesarean birth instead of having another vaginal birth. These are all great conversations where you go over your specific case and history with your provider to find a solution that seems best and right for you. Good news is that your team is ready and prepared if a shoulder dystocia is taking place. So the first thing that you might notice is they call out for extra hands. Then they're going to put the bed totally flat, removing pillows, and scoot your bottom down to the edge of the bed. All of these things are going to help increase that diameter of the top of your pelvis and bring that up a little bit to hopefully get that shoulder down. The next two maneuvers together relieve more than 50% of shoulder dystocias with no subsequent maneuvers needed. And this is McRoberts maneuver, where they help bring your legs back towards your head, and suprapubic pressure, where a nurse will stand up on a stool and actually use a fist or the flat part of their hand right above your pubic bone to help rotate or tuck that shoulder underneath, okay? These are the maneuvers that relieve a good number of shoulder dystocia, and then from there we will get into some that are used more rarely for more significantly impacted shoulders. So one other movement that we can try, particularly if you don't have an epidural or if you've got good movement of your legs, is to flip over in the Gaskins maneuver onto all fours. This is gonna allow gravity and that change of position to hopefully unstick your baby's shoulder, and sometimes even they will have you bring one leg up almost like a Renner's position to create a little bit more room in that pelvic area. One thing that your provider might do with a shoulder dystocia is cut an episiotomy. Now this episiotomy is not going to relieve the shoulder, but it would give their hands a little bit more room to maneuver inside of you, because some of our other movements involve them trying to either manually turn baby or a corkscrew maneuver, or to birth the posterior arm first. Now your provider is being very careful and very cautious because we do not want to have complications occur with you or with your baby, and those complications for baby could include a brachial plexus injury or a fractured clavicle or a fractured humerus. Now of course sometimes those things have to occur to get your baby out safely, because if a shoulder dystocia occurs and it's lasting more than 5 minutes, then your baby is not getting the oxygen that it needs, and that potentially could cause some significant issues choose later on. Now, I am going to go over really briefly a few more significant things that they might try during shoulder dystocia. If you're already at this video being like, I'm a tap out, I'll tell you when to skip ahead. The more rare maneuvers that we do are something called Zaffinelli's, where we push the head back up into the uterus and do a cesarean birth. The other thing that they might do is intentionally break a clavicle, get baby out. And the other thing that they can do very rarely is actually cut the pubic bone to help create more room for baby to come out. All of those things are super rare, and most of the time our other maneuvers are going to get baby out. Now, once your baby is out and here, they might need a little bit of resuscitation or a little bit of extra oxygen and a stimulation to help get them breathing. There is a higher risk for postpartum hemorrhage after a shoulder dystocia. There is a higher risk for 3rd and 4th degree tears with the shoulder dystocia, and kind of all of the other things that could come with that injury to the pelvic floor and to that perineal area. So these are all things that we're definitely considering when we're talking about preventing a shoulder dystocia. Now, I did already say that ACOG says that they are unpredictable and often unpreventable, but what are some things that we can do during labor to help ensure that your baby's coming down in the best position possible to give their shoulders the best amount of room to come out on 2 separate planes and for baby to do that restitution and that external rotation? Changing position every 30 minutes, even with an epidural, and asking and encouraging your nurse to help you change positions if they aren't doing that on their own. And then when we're pushing in different positions and changing that position every 15 minutes. All of this position movement and changes, we know movement is magical, can help rotate baby and help them find their way into the world the easiest way that they can. The other thing, if you have gestational diabetes, we just want to be really cautious of our blood sugars. We want to do our best to work with the dietitian, to work with our OB provider, to work with our endocrinologist to tightly control our blood sugars. And then we also just want to be active, moderately active during our pregnancy, and make sure that weight gain is not above kind of the threshold that your provider sets out for you. And if you're having difficulty, because it can sometimes be really difficult to control weight gain during pregnancy, it can be helpful to meet with a nutritionist or ask for a referral to a nutritionist to help you find a plan that works best for you and your lifestyle, because we know that weight gain and uncontrolled gestational diabetes can potentially have larger babies as a result of those, and those larger babies sometimes will get their shoulders stuck. Whew, I know that was heavy, I know that was stressful. I'm glad we made it through. The one thing that I do want to talk about, and I feel like this is almost, hopefully, if you've experienced a shoulder dystocia, a debrief. A debrief is so important after any delivery where things don't go textbook exactly to plan, because a lot of times there is a lot going on in the room, a lot of people talking, a lot of commotion, and time is almost moving in slow motion. Things are feeling really intense and really scary, and a debrief afterwards, as well as much as you need after the delivery, is the best way for you to take this event that is occurring, and instead of processing it as trauma, to process it as a memory, is to talk about your birth story, to share your birth story, and to do that you need to have all of the pieces of the puzzle. So asking for clarification is really important. Your OB, your nurse, should have debriefed with you after delivery, but if they didn't, or you don't remember exactly what happened, please ask them. Call and schedule an early follow-up appointment if you're having a really hard time wrapping your brain around everything that happened, because this was an obstetrical emergency, and that is scary. Even if everything turned out totally fine, it can be really scary and intense. So this is me right here, right now, debriefing a little bit with you, okay? I'm not saying this is going to replace your provider, but hopefully it kind of helps put all of the pieces into play. Your baby's shoulders got a little bit stuck on the way out, and so we did several maneuvers to help get your baby's shoulders safely delivered. So we put your head of the bed flat. We asked everybody to stop telling you to push, because we wanted to give those shoulders time to move and not just be constantly rammed into your pubic bone. The next thing we did is we helped to bring your legs back really far. This is to create more room for your baby to get under the pubic bone. And then the nurse was able to actually press right on your belly and help scoot that little shoulder under your pubic bone, and your baby was born safely after that. Do you have any questions? Right? That's what a debrief should look like. And that might not be your exact story, but that is the story that we often see with those shoulder dystocias, because remember, bringing the legs back and that suprapubic pressure does release most shoulder dystocias. So I hope this video was helpful in explaining what a shoulder dystocia is, in explaining what we do, explaining the few things you can do to help prevent them, and to know that your team is always watching out for signs of shoulder dystocia, and our goal is to keep both you and baby as safe as possible. Thank you so much for watching. Let me know if you have any questions. Did you have a shoulder dystocia? Let us know. Sharing our experiences and our stories is a really important part of healing and processing our birth as a memory. Thanks so much, guys. Bye.